august set of panelists. You have seen Rochan, Vimal, Indu, Viru, the team from all over the country are there as expert panelists who would help us with the questions. You are okay to add on to whatever questions you have as the talk goes on, but we'll pick them up as we finish towards the end. Okay. Okay, with that little introduction, this is the third in the series of ISVIR sponsored webinars. I think it's a great effort from Ajit, Arun, and the whole of the secretariat, and this is going to be very good. I actually quite enjoyed preparing for this. So the topic that I have today is technical tips in central vein angioplasty dialysis patients. Okay. Just 1 second, guys. How do you go to the next slide? Boys?
Just normally you just click it, next page.
It's not working. It is not working. Okay. Okay, right. So I was on your screen, that's why. Okay, can you see my screen now?
Absolutely.
Okay, just 1 second, boss. I need to minimize. So, so when we talk about access, how do we do an access? The access is usually an ipsilateral basilic or brachial vein. Particularly, what we try to do is to select a non-outflow vein of the fistula, particularly because we don't, the risk of bleeding is higher because we're going to put large French sheet size in this particular axis. So we want to avoid the risk of bleeding, but more importantly, we want to avoid the risk of the fistula going down in an attempt to open a central vein for angioplasty. But the ipsilateral basilic or brachial vein should be greater than 5 or 6 millimeter. Or if that is not the case, then we will go to the outflow vein, for example, which is most often, it is the ipsilateral cephalic vein. So you need this axis in addition, and or you need an axis in the femoral vein. And usually that is the site with which we do the angioplasty. And I'll explain how and why that works. Very rarely we will go to the ipsilateral jugular vein, particularly if we are going to do a brachiocephalic occlusion, because it is a straighter course, particularly for the right side. And you have got a much bigger purchase if you're coming from the ipsilateral jugular vein. So this is about the axis. Usually we start with a 5 French sheath and then we upsize depending upon where we are going to do the angioplasties from. I can't see my heading. So the straightforward angioplasty, plain, simple angioplasty. This is a patient with an occluded left brachiocephalic vein, as you can see, with a lot of collaterals. And we've done an arm venogram. We always start with an arm venogram. Some people do come with previously done CT venograms. What we find that the contrast venogram that we do by the standard method of injecting about 15 mils of contrast and then pushing it with saline gives us much more dynamic picture than the CT venogram does. So this is an occluded left brachiocephalic vein. It looks bad, but it was quite easily crossed with a MPA and a terumo. That's our standard catheter and wire technique to cross these lesions. It's usually a standard terumo, but in some cases we'll use a stiff terumo, as I will show you in a second. So crossed, once it is crossed, we go down into the IVC and we exchange for a stiff wire. It's an 035 stiff wire to the IVC. And then we will just do straightforward, we give some heparin, and then we'll give balloon dilate to 8 millimeter, obliterate the wasting. Sometimes it will go up to 12, 14 atmosphere, then go up to 12 millimeter, and then we'll do a run at the end of 12 millimeter. If the run looks like this, there is good forward flow, there's complete disappearance of all the collaterals, then we will stop. But we often go up to 14 millimeters, 16 millimeters, and very rarely 18 millimeters. The key is that how does it appear, not just the percentage residual stenosis, but how is the flow, how is the disappearance of the collateral. The patients say that almost immediately, they say that the arm feels a lot better and lighter. And those are also important criteria for you to go by to say, see what is the end point of your balloon dilatation. Regarding balloon dilatation times, I mean, there is some controversy. I mean, people talk about, we were taught when we were training that straight up, straight down. We now know that leaving it for a bit longer helps. Now, how much longer? 30 seconds, 1 minute, 2 minutes, we can have a discussion at the end. But I must admit that progressively, as I've got older, I leave them for longer. So I at least leave them, particularly the final balloon, whatever is your final balloon, I would leave it for at least a minute. And if it's not 10 o'clock at night, I would leave it for 2 minutes if possible. So I think we have learned this as well, that longer balloons does better jobs. Now, just let me go to some more complex cases gradually. So this is a patient which, as you can see, very grossly swollen arm with post-thrombotic, post-venous hypertensive ulcers. Is on hemodialysis, left upper limb swelling. He has a left radiocephalic fistula, left IJV line several times before. His right side venous access has gone, several fistulas. I'm afraid this is, I don't know about you guys, but for us, a lot of the patients that come to us is like this, where they have had so many accesses and they have come at a very end stage. So unfortunately, most of our venous angioplasties we do are more complex, and we will show you some cases. So here, again, this is a occlusion of the left brachiocephalic vein. So again, arm access, but we cannot cross from the arm. So then we will go into the femoral vein. We will have a second catheter from the femoral vein. And I don't know, I show my arrow here, but there is actually a very, very tiny and thin track connecting these two sites where the occlusion is. So at this point, we will cross it luminally or subintimally. We are not bothered. If it crosses luminally, that's what we try first. But if it doesn't, I'll get my catheter halfway up to the occlusion, make a loop, and then I will go with the loop and cross with the loop. I was initially reluctant to cross venous disease with subintimal, but to be honest with you, in the central veins, I've learned that actually subintimal works as good. Again, we can discuss this at the end. So, and what wires do I use? I first start with the standard 035 curved Terumo. Then, particularly if I'm at the point of the occlusion and I can see a little straight path, I can try a straight Terumo. But usually I'll go from a curved standard to a curved stiff. And the curved stiff often does the job more often than not. So I'll use an 035 curved stiff Terumo. So once I'm through, so we will have from the other axis a 5 French or a 6 French snare device, and we will snare the wire. And here is a tip, and I don't think it's written anywhere. This was actually discovered, within inverted commas, discovered by my nurse, who's a genius, Srinivas, who works with us. It was his suggestion actually. So when we were first starting to do this, obviously what happens is you're crossing with an 150 035 Terumo, right? So when you're crossing with an 150 035 Terumo, oftentimes you have run out of wire because you've got a catheter, you've got a wire, you've run out of wire because the wire will not go into the other side enough. Okay, so, or if you've crossed with a wire, your catheter is not going to track over the wire. So the wire has gone, but the catheter won't track. So then obviously there are two ways, right? You can snare, get it out of the other side, have a body floss, and then everything will track. Sometimes you are out of wire because you have used a 150 Terumo to start with. So in that case, what we do here is we do the snare, but we don't pull it out. We tighten the snare. So from the femoral end, somebody is pulling on the wire, and the tightly caught wire in a snare is also being pulled. So in effect, we have got a floss, but the floss is inside the body rather than outside the body. And then once you have got that, so this is a video, I don't know whether you can see it. This is on the right side. So we have snared the wire, but we do not have enough wire to come out of the arm sheath. So what we will do here is we will actually tighten the snare, and then we will push the catheter over. So this is a wonderful technique to cross the occlusion with the catheter. And then once the catheter is through, then we will use a 260 wire, oftentimes a stiff wire. We will snare the stiff wire again. And then once we have done that, we have got body floss. So this is just a way to get you to body floss when you are running out of wire. This is a very nice technique. So once that is done, then 12 millimeter balloon in this particular case, and quite good results. You can see the arm has shrunken significantly, and the edema has gone, and the ulcers have started healing. So this has been looked at, the feasibility and safety of a through and through wire technique for central vein occlusion in dialysis patients, and they say that this is a good. We all know this is good. In fact, more often than not, we do this through and through body floss technique when doing central vein angioplasties. So this is more or less our standard way of doing central vein angioplasties. Okay, now let me just come to some more difficult cases. Here is a long-standing occlusion, not crossable from the arm. We have tried. This is just a magged up view of the place of the subclavian brachiocephalic junction, which is occluded, as you can see there. And then we have come from the groin, and we have two catheters, one 5 French catheter, one 6 French catheter, and we're trying to cross, and we are not able to cross. Still, we are not able to cross. So in these sort of situation, our first port of call is to put sheaths. So we'll put a long sheath on one side or sometimes on both sides. So then you have got two sheaths from two sides and two catheters. So it is like a mother and child technique. So using a mother and child technique, you have got better support, you have got better pushability, and then we are able to cross through this occlusion, snare the wire, and then once we have got two support sheaths on two sides, it's a biaxial system, a mother and child, and it works in most number of cases. So once you have done that, again, you just cross 8, 10, 12, and then you do the angioplasty. Now, if you're looking at this, you might say that the cephalic insertion does not look so good. It had a recoil. We would have dealt with it separately, and we will pick up this case towards the end of the talk. But our target site, which is between the two arrowheads, the brachiocephalic, looks quite good, right? So we have done a successful angioplasty here. Now we have also done mother, child, and grandchild, which is a triaxial system. So 6 French catheter, through which, 6 French sheath, long sheath, through which we have put a 4 French catheter, through which we have put a 2.4 French, one of these peripheral microcats, and then a 014 wire. And we have done that. We have done the sharp end of the 014 wire, the soft end. We have done both things, but this triaxial system, very rarely. So this is just an example: 6 French, through which a 4 French, through which a 2.4 French, and then you are able to cross. So this is a triaxial system described by the Japanese in the setting of TACE, as you know, in doing difficult TACE, but actually it is also a very good device to cross. Once you have crossed with an 014, it is better to do like a little cardiology or one of our 014 balloons, to do a little balloon on the 014, because even after the 014, your catheter will not track over the 014 wire. So you need to do a little balloon after you have snared the 014 wire, and then convert it to an 035 system and finish your angioplasty. So this is a triaxial mother, child, and grandchild system. Very rarely used. I maybe have used it maybe 4 or 5 times in our career. So this mother-child technique has been well proven, again, in the literature, successful in 36 out of 36 cases in stenosis. Although you would question yourself that why did you use a mother and child technique for stenosis? We only use it for occlusions, and in 43 out of 45 cases with occlusion in this particular paper. So let me talk to you about a third technique now, actually getting into a vessel which you do not intend to get at. So for example, here, our aim was to do one-sided angioplasty, any one side. I can't remember now which side was the more relevant side. But bilateral venograms show complete occlusion of both brachiocephalic veins. So in this case, coming from the right side, we were not able to cross into the SVC, but we were able to cross into the left brachiocephalic vein. As you can see here, I think there was a little bit of sharp, probably, I don't know whether you can appreciate, it's probably the sharp end of the wire that is being poked. So maybe I can't remember now, but we probably did a little sharp. And then we got into this particular bit. Then we grabbed it from the other side. So we got into this collateral vessel. We grabbed it from the collateral vessel. And then we did an angioplasty to the left side. So now we have got a communication between left and right. And now when we do an angiogram, we can see a little bit of contrast coming from the left to the SVC. There was no contrast coming from the right to the SVC. Now we have got a communication from the left. Now we can convert this into 2 wires down both sides, kissing balloons, which I haven't shown you, kissing balloons, and then a beautiful result at the end. So what I mean to say is that even if you're not able to cross from the subclavian to the SVC, if you're able to cross to the left side, then get your wire catheter down the left side, and then you're able to cross and do an angioplasty. Let me show you this example of a lady. As you can see, hugely swollen left upper limb, big dilated right-sided veins in the superficial external jugular vein, etc. She has got a working brachiocephalic fistula on the left side, but has a large swelling multiple neck, chest, and facial collaterals. There is flexion deformity of the fingers and inability to close the fist, unable to bend the elbow. These are two clinical parameters I use to determine how urgent is this central vein angioplasty. When the patient comes to see you, do ask these questions. Can the patient close a fist? If the patient cannot close a fist, they cannot do the daily household work. Can they bend their elbow? Because otherwise they cannot eat. Is there any ulceration, any skin damage to the vein? So these are all urgent indications to do a central vein angioplasty. So this particular lady had 2 failed attempts of central vein angioplasty elsewhere. So similar to the last case, what we have got is widely disparate occlusions, as you can see on both sides. We are not able to cross, but from below, from the femoral vein, we are able to cross into one of these veins. Sorry, I don't have my arrow, but I don't know whether I think you can see my wire. The big fat vein is the internal jugular vein, but my femoral wire has crossed into one of these collateral veins, probably the external jugular vein. So now we can get, therefore, from the arm, we can get a catheter and a wire into the same vein. So here it is, it looked like that we have got into the same vein, but it wasn't the case. As you can see, when you oblique, you see that the 2 wires are in 2 different veins. So this picture has been drawn by Dheeraj very nicely. And as you can see here, that actually the 2 wires, one was in the internal jugular vein, one was in the external jugular vein. So on one projection, they looked good, but on different projection, they are on different planes. So then what you do is you withdraw your catheter, get into the vein in which your femoral wire is, and then you drag it, you catch it with the snare, then the rest is easy. You do an angioplasty. And this is the lady after 1 day, and this is the lady after 9 months. The good results. So what I mean to say is that if you can get into a collateral vessel from anywhere across the occlusion, don't lose heart. Try to get into the same collateral vessel from the other axis. If you are able to do that, you can snare it from that vessel, and then you have a through and through body floss. So I think, okay, this is probably okay. So again, trying to cross. This is a long brachiocephalic occlusion. Trying to cross, similar again. So we have got into a collateral vessel, and then snared it from the collateral vessel. Then we have got a through and through, and then we have done an angioplasty with a good result. Now, this is my typical consenting or counseling of a patient. So I put the dialysis history, dialysis for 5 years, right IJV line, left IJV line, failed AVF several times, left femoral AV graft for 3 years, left pump cath for 1.5 months. So I write all of the access history. Then I do a clinical examination. As you can see here, I talk about can make a fist. I can't read my own handwriting, but you know, there's a good thrill. There is a can flex the elbow to 70 degrees. So I have documented all of this. Then we counsel, we explain what we do. We put the patient on dual antiplatelets. Sometimes if we feel that the patient is a little bit thrombotic, prothrombotic, we like some anticoagulation immediately previous to the angioplasty, maybe about a day or 2. I know that nephrologists don't like using Clexane, but if you do use Clexane, use it at a lower dose, 20-40 milligrams, because you know, giving warfarin is a time-consuming affair. So I do like a little bit of anticoagulation beforehand, and I'll tell you the reason why. Because we do a little really torture the veins. You know, the way we cross, balloon. I see Virendra smiling, and we do a real torture. So I think leaving them slightly in an, you know, anticoagulated state, I think prevents significant amounts of thrombus. Number one. Number two is vein is a low flow state, unlike the artery. So I think, although I realize that we increase the risk of intracranial hemorrhage, and I've had 1 death secondary to intracranial hemorrhage, but generally speaking, I find it quite useful. So so we've used all the standard techniques and we have failed. We have tried support, we have failed. So this is the time when I would use a sharp. When you're using a sharp, remember one thing: you need to be in a straight portion of a vein. You cannot try to do a sharp from the cephalic into the subclavian. Try to sharp coming from the jugular into the brachiocephalic, that's okay. Left is okay because you need to go into a sharp, relatively straight, predictable technique. Once you've gone through the sharp, sometimes I'll just push the catheter if I'm really brave, because you know, the other thing is you do get a feeling once you do the sharp. once you've gone through, you get a feeling, and the feeling could be extravascular too, I guess. But there is, with experience, you get this little feeling, and you know that you are in the vessel. If you are confident you're in the vessel, you can push the catheter over the sharp part, but it's usually safer to just see whether you can snare, because if you can snare from the other end, then by definition you're intravascular. So then we just hold the snare in that place and we push the catheter through. So back end of Terumo, and then we do an angioplasty, and then it's a good result. Now here, for example, there is a single collateral that is still showing. So this is an argument to maybe consider doing a bigger balloon. Maybe we have done a 14. First time we don't go to 16, but if it was the second time, I would go to 16. So there are lots of other ways of recanalizing. Radio frequency wire recanalization, I haven't done this. I have done an outback technique in the UK, but not here. We don't have the outback. Laser recanalization of central vein occlusion, similarly. Then the Japanese have done this long Shiba needle. They have used a long Shiba needle through a short catheter. They've done an axillary vein access, and then, or a subclavian access, and then they've used a long Shiba needle to puncture and penetrate. And of course, using an outback re-entry catheter. So these are all various techniques. But to be honest with you, the back end of the Terumo works almost all the time. We'll take a little poll at the end. Now I want to show you this little picture. And this is perhaps a slightly, or at least this wasn't a concept that I was aware of or I had read anywhere early. We learned it the hard way, and then we have found that this stuff is in the literature. So I want to highlight this very important point. So this is a pre-angioplasty. You can see an occlusion of the left brachiocephalic vein, or rather stenosis. It was very easily crossed, very easily ballooned, hardly any wasting. At 6 atmosphere, it was up. But you do the post-angioplasty and you see a result like this. It is not good. There is still, so your first thought is this thrombus? Okay. It wasn't thrombus. I can tell you, we did some runs and it was not thrombus. So now I've learned it the hard way. So we now do this cone beam CT at this point. So this is a cone beam CT. And the cone beam CT shows you that the space in the retrosternal space between the aorta and the bone is only 6.2 millimeters for the brachiocephalic vein. Now then we started investigating this, and we found that actually there is a paper talking about the variability in this space for the left brachiocephalic vein amongst normal asymptomatic individuals with a stenosis of the brachiocephalic vein. This only comes to importance when there is a high flow dialysis setting. In a normal patient, it doesn't come into being. So actually the percentage is about 14-15%, so it is not small. So this is, you can see this is 6.2 millimeter. The mean space in a normal individual is supposed to be between 11 and 14 millimeters. So you can see that it can be reduced in some people and it can be a cause. Now, if you have something like this, then any amount of venous stenting, any amount of angioplasty is not going to do any good to you. So if you want to do a sternotomy, that's great. But I would suggest that these are cases when you need to go to your surgeon and say that consider doing a veno-venous bypass or something else, rather than actually trying to do an angioplasty in these cases. And I will show you examples of the importance of bony thorax in another case, which is much more common. So this is actually in the literature now, outcomes of venous bypass combined with thoracic outlet decompression for treatment of upper extremity central vein occlusion and management of central vein stenosis occlusion, the critical importance of the costoclavicular junction and the importance of the first rib. And I will talk about that in a second. It is certainly an under-recognized entity, and it is certainly an entity in the setting of recurrent venous obstruction or stenosis. Certainly we look at it, if a patient comes back quite soon, we have realized that this actually is the cause. Rather, if you have dilated to an adequate amount, then this almost certainly is the cause. So in our experience, 4 patients have had the surgery and the results have been very good, and I'm going to show you one of those cases. So let me just talk to you. Okay, so this is the final case actually, and this is the same case as case 2, the case where we had the 2 support catheters. So this is what I'm talking about. 57-year-old lady who came with a highly swollen right upper limb, painful flexion deformity at elbow and significantly engorged breast. extensive collaterals on the chest, shoulder, and right upper limb, previous angioplasty done by us. On examination, there was superficial ulcers and excoriation on the right upper limb. So you've seen these pictures. We have crossed how we crossed, and we did an angioplasty. Angioplasty, that was a wasting. We did an angioplasty. And we talked about the cephalic didn't look good. We put bigger balloons. And even at the end, look at the bottom right picture. Even at the end, the picture wasn't very good. It wasn't great. Okay. So the swelling did not subside. So we repeated a venogram. And on repeating the venogram, we found that there is significant recurrence and recoil of the place where we had done the angioplasty. So we did an angioplasty again, and we put a stent this time. This was I can't remember, it probably was a 19 or something like a 14 dia, 1460 odd stent. So we put one of these dedicated venous stents, and as you can see, even with the stent, guys, can you see this? Even with the stent and a post-stent dilatation, there is this indentation. And see how that indentation is on the inner border of the first rib. This is where this was one of the first cases we started suspecting this. And we did a cone beam CT, and look at the cone beam CT. This is the indentation by the first rib on the stent. Now, therefore, however much you think that you have done a dilatation, this is not going to work. So as we suspected, 8 months later, this lady comes back even with a worse upper limb swelling and deformity. Okay, this is the state of her upper limb. So this time I was in England, and this was Dheeraj and Partho. So they tried to cross it from, they couldn't cross. They couldn't cross this recurrent stenosis. Usually recurrent stenosis are easy to cross, usually. But this was not the case. So they tried, and then what they did was very nicely, you can see the occlusion there at the point. What they did was they actually did a sharp inside the stent, and they had a snare catheter open, and there is a sharp inside the stent. Unfortunately, I don't have an arrow or a pointer, but I hope you can see there is a 6 French sheath through which there is a catheter, through which there is a back end of a terumo, and that has been grabbed by the snare catheter. And then again, the same principle of giving it a tug, and whilst giving it a tug, push the catheter in. So that was the idea. And once that is done, you do the angioplasty, right? And this time done up to 14 millimeter, went up to 38 atmosphere. So use one of these high pressure inflations to go there. And it looked pretty good. It looked good. It looked that the stenosis had been cracked, and things have been done. But to be honest with you, she looked good short term, but she represented again. And this time we followed this by a first rib resection and then another angioplasty. And she's okay for 14 months after the first rib resection, anterior end of the first rib. And my surgeons tell me that this is not such a difficult operation. So what are the learning points from this case? So this one case actually gives you all the learning points that I was trying to talk about today. Use of support catheter to cross tight occlusions, use of the body flush technique to allow device passage, use of stents in resistant or recoiled stenosis and its pitfalls. I am not a great fan of stents. I know that there are people that put stents if there is a 30% recoil. I have learned my lesson that even in those patients, there is restenosis. I must admit to you that we are going to publish this. I mean, the 130 odd cases of central vein occlusions. I mean, if Dheeraj is listening, he needs to, finish writing this article up. Our median patency is much more than what is described in the literature. It is close to 17 to 18 months. And I realize, and this is without stents, we have only used stents very sparingly. And I've realized that the cases where we use stents, actually we would have been better off doing the surgical rib resection and a repeat angioplasty. This is a personal opinion. I know that the literature is replete with covered stents and Viabans and things like that. I know that Viru uses more stents than we do, but it's people's opinions will vary, but it's my own personal opinion that the bony thorax is very, very important. And actually the stent, probably because of the bigger framework, is able to push for a bit longer perhaps. Use of sharp recanalization techniques in uncrossable lesions, the role of thoracic decompression in appropriate cases, and the role of cone beam CT I talked about. And I think appropriate realistic goal setting for the patient. The patient comes to you, you spend 70,000 to 1 lakh rupees. And their initial response is that, okay, doc, you're doing this and it is going to be forever. So I think a realistic goal setting that this is not going to be forever at the beginning establishes the rapport and the faith of the patient. So with that, I would like to thank you. I would just like to go finish with this message, which actually, to be honest with you, was actually learned from my younger colleague. Rule number 1, do not let go. Rule number 2, if you are very tired and it is 9 o'clock, follow rule number 1. So that is something that we have been following in the cath lab, and I would like to thank our team at NH Kolkata, particularly Sundar, who sent some pictures, Parthu Srinivas Pillai, who is always there standing at the back and giving some lovely ideas, and our secretaries. And special thanks to Dheeraj for the quote above. The quote that I gave you above was his. And actually for being there till 10 p.m. and doing these cases. Thank you very much.
Thanks. I don't see any questions. Any questions, anyone?
Are we there? I can't hear you guys.
Shuvro, can you see the question?
Oh, yeah, there.
Can I see the questions? 1 second.
Yeah. Go to the Q&A at the bottom of the screen. Q&A.
Okay, just 1 second. Let me make this bigger first. Okay. No.